Alright, hello all. I did my project on antisocial personality disorder. The diagnostic criteria of which include 3 of any of the following. 1. Failure to conform to social norms with respect to lawful behaviors as indicated by repeatedly performing acts that are grounds for arrest. 2. Deceitfulness as indicated by repeated lying, use of aliases, or conning others for personal profit or pleasure. 3. Impulsivity or failure to plan ahead. 4. Irritability and aggressiveness as indicated by repeated physical fights or assaults. 5. Reckless disregard for safety of self or others. 6. Consistent irresponsibility as indicated by repeated failure to sustain consistent work behavior or honor financial obligations. 7. Lack of remorse as indicated by being indifferent to or rationalizing having hurt, mistreated, or stolen from another. And I missed one. That was reckless disregard for safety of self or others. Alright, additionally, there's an addendum. The individual has to be older than 18 years of age, and so to kind of help you guys distinguish between what you're sort of going to find in the field, you'll find oppositional defiant disorder among the youngest, and then there's a kind of gradation between that and conduct disorder, and then once they hit 18, it's sort of like ASPD is what follows. There also, on that note, there needs to be evidence that conduct disorder was present, or at least had some of the symptoms prior to age 15. And finally, of course, you have to distinguish it from schizophrenia or a manic episode. As for differential diagnoses, those include substance dependence disorder, the means by which they, find that drug or, meet that fix aren't always legal. I mean, given the illicit nature of drugs in the first place, it would make sense that they're going to sort of circumvent the law in order to find that. So it's important to tell the difference between the two, since a lot of the criteria refer to lawful behavior. And the way that you would tell the difference between the two is looking at patient history, really. For ASPD, chronic disorder should be there before age 15 because it's more of a, they view it as an innate, sort of crystallized trait, whereas something like substance dependence disorder can occur whenever, more or less whenever. Another differential diagnosis for it is narcissistic personality disorder. The way you distinguish antisocial from that would be looking at whether or not the client possesses emotional cognition. Because a big point of difference between clinical narcissists and antisocials is that antisocials are exploitative, they have superficial value systems, incapable of guilt, allegedly, and so that's part of the formulation of antisocial, whereas when you look at narcissistic personality disorder, they are actually capable of feeling or representing or even articulating, in many cases, guilt or remorse about the way that they're manipulating people. Whether or not that carries into action, the emotional cognition, or at least the capacity to understand that, still exists. Now, moving on to etiology. Of course, there are nature and nurture theories. All that is kind of turned on its head by epigenetics, but for some reason that hasn't carried into the pertinent research yet. Maybe in following years that'll change. But as for nurture theories, they look to childhood trauma as a fairly good predictor of whether or not they're going to, first of all, develop something like oppositional defiant, and if that progresses to antisocial. Two sort of components of childhood trauma that are really good predictors are whether or not there was a presence of either abuse or neglect. In addition to that, if there are any parental figures with antisocial, the children are subsequently exposed to a much higher risk of developing the disorder. And as for the nature theories, they look to things, scientists looked at things like a correlation between the volume of prefrontal cortical gray matter and autonomic activity. A lot of research has been done that suggests that antisocial individuals don't register the same anxiety response to anticipating fear or carrying out unlawful behaviors. The implication being, of course, that they don't feel. I find that research highly suspect, especially when you're just looking at a random part of the brain trying to determine if there's a causal link between behavior and that, because human nature is such a complicated thing, and that's really what antisocial personality disorder is trying to get at. These people are like this, and it's not going to change. It's sort of a part of the definition of personality disorders as the DSM describes it. So I would hazard all of you against sort of believing that credulously. Like I mentioned, low on neuroticism as it relates to personality theory, low on anxiousness, dampened autonomic response to pain. I alluded to this before, let me go into it in more detail. So studies suggest that ASPD actually precludes the usual bodily responses to stress in a situation where they're in danger, or in a situation where they're doing something they know they're not supposed to be doing. They don't register an elevated heart rate. They don't show the same degrees of bodily sweat, for instance. And again, the idea being that they just don't have it in their emotional cognition to comprehend the right or wrongness of these actions. Again, I think that's up for debate, but that's unfortunately what a lot of the research points to. As for treatments, cognitive behavioral approaches are championed a lot. The research suggests that these approaches generate the largest clinical improvement. One kind of tripping point there, or maybe an addendum you might want to add, is that most of the money goes towards CBT research, and consequently that's where you're going to find a lot of the support to back its efficacy up with. I mean, I'm not saying that the alternative has to be psychodynamic, but if you look at other approaches, maybe Rogerian, there's just not the same amount of money in it. And so of course you're not going to find as positive clinical results from those kinds of things. I mean, you might in individual studies, but a lot of it is a visibility thing. And pretty much all I saw were CBT studies. And so when CBT tries to address this particular disorder, it looks to a system of rewards and punishments for good and bad behaviors, respectively. And so one caveat for that is that CBT approaches largely only help with empowering the client to avoid incarceration. And so you want to make sure you're not just making more successful criminals. If you've ever watched The Sopranos, you remember the subplot of him meeting with his therapist, and the therapist being sort of ambivalent about whether or not she wants to carry on with him, because sometimes she said she felt that she was just making him a better mob boss. And that's definitely a point of contention, at least as it relates to CBT, because not all approaches work on just rewards and punishments, but this is the sort of prevailing one right now. And so the second caveat is that CBT does nothing to teach the client why certain acts are wrong. And again, that's practically a part of the theory. People respond to rewards and punishment. If you look at classical behaviorism, if you want to call it Skinnerian maybe, I don't think they see much in terms of human motivation besides rewards and punishments. And so of course CBT isn't going to show a lot of that. I haven't found other studies that suggest otherwise, but again, that might just be because all of our money is going towards CBT treatments. One hopeful treatment study that I found was about supervised residential programs. They incorporate peer confrontation, and that sounds really stuffy, but it's really just, the scientific way to say, or jargon-laden way to say that they just encourage human contact, and people that they live with sort of call them out when they're being manipulative, make explicit these things, and try to impress on them the sort of consequences of what they're doing and how they're hurting someone for it. And so what seems nice about it is that they incorporate a safe environment for the client. They try to replicate what a healthy life would have looked like had they not grown up with abusive parents or neglect, which is largely the case, as research suggests, and I mentioned that before. It also offers insights into the client about the moral dimensions of their actions. I said that before, but I think that articulates a little bit better. And so, I mean, we don't want to assume that every client has sort of succinctly had it portrayed to them what right or wrong actions are, because that may have been the case for us. But in the case of neglect, who knows who was raising them and who was inculcating whatever sorts of values on them. And that's the end of my presentation.